The broadcast is now starting. All attendees are in listen-only mode.
Hello, welcome to today's Simulation IQ webinar. It's hosted by Education Management Solutions and the Global Institute for Simulation Training. The topic of this presentation is simulation, why it's imperative to discharge teaching. Our speaker today is Linda Hutter, Staff Development Specialist and Lead Simulation Educator at Mount Washington Pediatric Hospital in Baltimore, Maryland. My name is Chris Qualtieri from Education Management Solutions, and Lori Kearns and I are happy to serve as your webinar hosts today. Even though you are in listen-only mode for the webinar, we invite you to participate in the discussion. In the GoToWebinar pane, you should see a red arrow, and that will let you open and close your control panel. During the presentation, you'll have the ability to send questions to our webinar staff from the questions section. So simply type in your question in the text box and then click send. At the end of the presentation, we will address as many of the questions that we have time for. You can also tweet about today's webinar using the hashtags GISTWebinars or EMS webinars. And yes, today's webinar is being recorded. Within the next few days, you'll receive an email with a link to the recording and to the slides. We also invite you to provide feedback about today's webinar. There's a brief survey at the end of the session. Please make sure your pop-up and security settings will allow you to access the survey. It will open automatically when you exit the webinar. And now we are ready for the presentation. So I'm going to introduce today's speaker, Linda Hutter. She has worked in her current role as Staff Development Specialist and most recently Lead Simulation Educator at Mount Washington Pediatric Hospital for over 10 years now. Prior to joining the education team, Linda had extensive experience of over 22 years as a bedside respiratory therapist at both Johns Hopkins Pediatric Intensive Care and Mount Washington Pediatric Hospital. Her passion for both simulation and education inspired Linda to lead an interdisciplinary team in developing a pulmonary pathway and tracheostomy transition. This would be transition for home teaching program, and that's at the Mount Washington caregivers. It's at Mount Washington, for caregivers of critically fragile children. Linda received degrees in education from Towson University and respiratory therapy at Baltimore Community College, and she's currently working on completing certification as a simulation educator. So welcome, Linda. We're glad to have you here. I am going to now change the presenter to you, and I'll let you know when we can see your screen.
All right, very good. Thank you, Chris.
Good to go.
All right, very good, everyone. Thank you so much for joining us. I'm excited to share with all of you this afternoon a little bit about our story here at Mount Washington and how by taking innovative approach and incorporating simulation into our transition home teaching, how it really honestly made an amazing impact into the safety and the safe transition to these kids' home. I want to show you how our story will fit into the bigger picture, your story, and patient safety. Like Chris had stated before, I've been in the healthcare field for a long time. I started out at Johns Hopkins as a bedside therapist, where at that point my role really was to stabilize these kids. I saw them for the first time. I saw families minutes to hours after receiving a tracheostomy. They stayed with us for several months and then were transitioned off to a place like Mount Washington, where they stayed at that time. Lengths of stay were anywhere from months to years. But I'll tell you right now, this is an exciting time to be in healthcare. Things are changing, and they're changing rapidly, so we need to change with the times. The advances that we've seen in healthcare technology, that we've seen in the last couple of years is amazing. In fact, children who used to remain in these hospitals, due to the advances in technology, are now being sent home with trachs and vents to families with sometimes very limited nursing care. That is why now in the next hour I would like to share with you why it is imperative that I feel that you need to include simulation into your discharge teaching. So simulation is not new. It's been around for a long time. I can think back to 10th grade driver's ed. When the instructor had us, before she would allow us to get behind the wheel, she sat us behind a simulator, and it was pretty darn real. It allowed us to test out our brake reflection, You'd be driving down the road and somebody would cut across the road and you'd actually have to hit the brake. It was effective. It was real. The problem with these simulator labs in the school systems, they were cost prohibitive. So they became a budget issue. And that's something that we're going to talk about at the end, because I know that's a big question that a lot of you have, that this all might be good and great, but what about the budget? So we're going to talk about that. Simulation also has been used to train pilots since the First World War. It allows for safe training that would otherwise be too dangerous to practice. So one of the things before we get started, I'd like to ask. I want to take a poll here. So Chris, I'm going to hand it over to you to ask a couple questions if you don't mind.
Awesome, thank you. So our first question here is, do you use simulation in a hospital setting? So please select one of them, and I will give you another couple seconds. Right now it looks like the majority, slight majority, are saying yes. So I'm going to close the poll, and it looks like we have 55% saying yes, they do use simulation in a hospital setting, and 45% saying no. So a follow-up question to that is going to be, how are you using simulation in a hospital? So are you using it for staff only, for caregivers only, or for staff and caregivers? As I look at the results here, it looks like the majority is for staff, not a lot for caregivers. So that'll be an interesting discussion after, since we're going to be talking about caregivers. I'll give it another second. And let's close that and share the results. The results are that 77% are using for staff only, 3% for caregivers only, and 21% for staff and caregivers. So Linda, we can see your screen again, so you can continue.
All right, very good. So that's not surprising. It's not surprising at all. Medical simulation has been around for a long time. It was greatly practiced in medical schools and nursing schools. And most recently, it's been used in hospitals to teach interdisciplinary teams. In fact, one study that showed that simulation-based knowledge that's acquired in a simulation lab is transferable and transferred to improved bedside skills. And the reason for that we need to think about is because the way it aligns with adult learning. As adult learners, we like to recall what we've already learned. We like to bring our life experiences into our learning. We like hands-on. We like to touch it. It allows us to retain it. It allows us to apply it. So we're going to talk a little bit about simulation. When you talk about simulation, there's a lot of different options that you have, anywhere from low fidelity to high fidelity. What fidelity really means is making it real. But the bottom line is you don't always have to have the high fancy simulation dolls. If you take a look here, this was taken a couple years ago. That's one of our respiratory therapists and one of our physicians practicing airway management. We made a decision, I think it's been about 5 to 6 years ago as a hospital, to incorporate laryngomask airways on our airway cart. It was a practice that would have been unsafe to practice at bedside, and to send them to other facilities would have been too costly. So we brought our staff down. At the time we were in a classroom. We used a low fidelity doll, which was quite adequate to show airway management, and they worked together as a team. Another important component when it comes to simulation that we need to talk about that ties it all together is this debriefing piece. I know we use it at the bedside a lot after codes, and it's proven to be effective. It is said that this is where real education and real knowledge begins. It's a chance for us to play back, to recap our performance outcomes. It's a place to ask those questions where, how do you think it went? What do you think went well? And what do you think we need to work on? It really helps us to bridge together that gap between simulation and transferring those skills to the bedside. So Mount Washington Pediatric Hospital, you can see it here. We sit just outside of the city. Our patients are fed from University of Maryland and Johns Hopkins. It's a place, like we said earlier, that I've called home for probably over 15 years now. We've used simulation since the time I started here. One of the things that we did, we used low fidelity dolls to teach CPR, and it was quite effective, and remains still effective to this day. So you need to think about, as we start progressing here with simulation, you always need to be thinking about what is your objective. So when you get a room together full of, as you see here, our psychology department, it made the most sense. It was cost prohibitive to bring them into the sim lab at that point, and they really honestly needed to learn those hands-on skills. But in 2007, we were awarded a grant from the Mount Washington Foundation. We were able to purchase SimBaby. Talking about kicking up our realism, it truly did. This is a high-fidelity doll. It's one of the first. It has real pulses. It breathes. Its chest rises and falls. So as you can see here, here's one of our young nurses. She's practicing a head-to-toe assessment. Something on a low-fidelity doll is really hard to get buy-in. They don't believe it. It doesn't look real. Well, I can tell you right now, this doll looks real. One of the most important things I want to share with you as we progress in our story, which will also hopefully become your story with simulation, is you've got to get creative. So I don't know if you can tell here, if you look at this picture, this really does look like a bedside. I can tell you right now, this is a classroom with 4 plain walls. So one of the things that we did to get creative and to kick up the realism at that point, because we were housed in a classroom, was if you look at the backdrop there behind this young nurse, it looks like a bedside, doesn't it? A patient bedside. We had one of our administrative gals who also had a love and art for photography take a picture of a real bedside. What she was able to do for a very low cost, I think it cost $150, to transpose that picture onto a cloth that was able to be hung behind the patient's bed, automatically transitioning it into a real life looking bedside. Something else that we did to get creative was if you look at this crash cart that's sitting behind one of our physicians here, that crash cart was actually bought for a couple $100 off of Craigslist. And I'll tell you right now, when we bought it, it didn't look like that. I think it was actually, at the time, it was solid red. But again, to get real buy-in, we had to mimic what was being done at bedside. So with a little bit of masking tape and a little bit of paint, we were able to create that. And there you go. We received quick buy-in and good feedback from our staff. So again, as we continue to get buy-in from our management and staff, we recently were awarded a grant, and a private grant and donations from our annual gala, and we were actually able to build a simulation lab. Now this is a 1-bedroom, which holds 2 patients. If you look here from this angle, you can see our baby, and a minute across the room, you're going to see a second bed that was set up with an older child. As we talked about before, we've been using low fidelity for a long time. You remember, if you recall the picture earlier with our respiratory therapist practicing airway management. So we knew independently that each of our disciplines was strong in their discipline. Respiratory therapy, without a shadow of a doubt, they had it down. They had airway management down. You look over here at our nursing staff, we knew because of the early nursing competencies that they knew how to do their medication calculations. They knew how to administer their drugs. But the one thing that we really had a hard time prior, and we asked them to communicate. There was a recent study taken by JACO that stated that 70% of all sentinel events in hospitals occurs due to lack of communication. So by having a sim lab and kicking up the realism, we were allowed to bring our interdisciplinary staff up to the sim lab. And at this point, and what you're looking at here, actually, we about 1.5 years ago implemented new code drug sheets. It was a practice that would have been too costly and too unsafe to practice at bedside. So we brought our interdisciplinary team up here to the sim lab, and we ran through a real-life scenario using the new drug sheets. I'll tell you right now, we found errors. Errors that if we allowed that to have gone out on the unit would have been costly. Here in the sim lab, after we debriefed and talked over, we found out what the holes in the system were, and they were easily fixed. So we have to ask ourselves, and the question that I'm going to ask you is, with all this attention being given to clinical staff, why is it that unplanned readmission rates still remain so high? There was a recent study out of Los Angeles Children's that documented that as high as 40% of all unplanned hospital readmissions in the first year were due to tracheostomy-related complications. There are approximately, at this point, 8,000 mechanically ventilated children in homes in the United States today. This can all be accredited to what we've already talked about, the pediatric survival rates, home mechanical ventilators, and the desire to control healthcare costs. Although there remains no standard yet for home care nursing, hours of approval vary from anywhere from 8 to 24 hours. The caveat here is that the ultimate survival of these fragile children literally rests in the emergent tracheostomy and ventilator skills of their parents and caregivers who have little to no medical background. So if you take a look here, up until this point, about 2 years ago at Mount Washington, most of our discharge transition home teaching was done on the unit and at bedside. We used, as you can see here, one of the low fidelity dolls with a trach. Here you see a picture of a nurse and a mom giving a bath, something that is scary for the first time. So the mom was able to practice on the doll. We also, a lot of times, will practice right on the patient themselves. Respiratory therapy handles our airway management. They'll let the parents a couple times practice on a low fidelity doll, putting the trach in and taking it out, putting the trach in and taking it out. I can tell you right now, most parents and most adults are teachable. You can actually teach them this skill. But the question that we had to ask ourselves, was there any real proof with these low fidelity mannequins and teaching these skills that it could be transferred to the home in an emergency situation with your emotions flying? We had to ask ourselves that question, and that's what we started to do. So this is where it started with Kaylee Klatt. Meet Kaylee. Kaylee was one of the smallest babies born. She was a preemie. In fact, she was a micro preemie, weighing in, I think it was 11.6 ounces. Up until this point, Kaylee's life had been touch and go. She lived in the ICU, her mom barely being able to touch her. The day came, though, when Kaylee was transferred, I think it was the age of 6 months, to Mount Washington. At that point, she was brought to us to be weaned off of her vent, and they were given a timeline of, I think it was 6 to 8 weeks, to learn everything they needed to know to care for their medically fragile child. And now I want to introduce you to Nicole. Nicole is Kaylee's mom. Nicole is educated, she's smart, and she's loving. She was the whole package. But for some reason, she just was not ready to trade on Kaylee. She was still getting used to this new norm. But yet she was given that timeline of 6 to 8 weeks. So our phone was ringing off the hook. We were getting calls from the bedside and saying, we've got a mom at the bed that won't train. Well, I'll tell you right now, when we met Nicole and brought her up to our sim lab, it wasn't that she didn't want to train. She was scared to death. So we had seen all the success that we had had with our clinical staff. So we brought her and removed her away from all of those distractions and all of that stress, and we afforded her the same. So we brought her up to the sim lab, and she got to play around. So right here, you're going to see Hal that was on the other side of the room. He's our 5-year-old simulator. And the thing that works really well with him is he actually has a tracheostomy and can be placed on a vent. So there you go. We've kicked up our realism. Mom was able to practice suctioning, something that can scare the heck out of a mom, but she was able to practice time after time after time again until she got it right in a safe environment. You take a look here, something that we all take for granted, the use of an ambu bag, but something that soon after discharge will become mom's lifeline. She got to practice time after time, as many times as she wanted, getting comfortable with that vent. Here she is playing around a little bit, touching the vent. Something up to this point was unheard of. And then we finally got to the point with changing the trach. Mom practiced it over and over to her, and with each time that we practiced, I saw her confidence get higher and higher. After this session in particular, it was kind of exciting. We watched Mom's confidence get to the point that she actually verbalized and went straight down to the bedside and changed Kaylee's trach for the first time ever, and did it quite successfully and confidently. Next, I'm going to show you, I want Mom to share her story herself. It's a story that I think will give you a good perspective. So Chris, I'm going to hand that over to you.
Awesome. Thank you so much. Beautiful. Thank you for sharing that. I'm going to hand the controls back over to you, Linda.
Absolutely.
Awesome. Thanks.
All right, good. Absolutely. Thanks, Chris. All right, so as you can see, that SimLab experience was life-changing for Nicole. And this was our aha moment as an education department. We realized that we had to give the same quality to every caregiver and every patient. The problem was we had limited resources. At that point, we were a department of 4. And at that point, we were responsible for hospital-wide education. So we sat down and we put together an interdisciplinary team. We called monthly meetings. We met, I think we met actually until we had this finished product that I'm about to explain to you. I think that actually took us a year. It was a year of monthly meetings for about an hour. It was social workers, case management, RNs, RT, education, medicine. and we actually included the home care RNs as well. So what we wanted to do is we wanted to get an actual picture of everything that went in to the discharge of these kids. 6 to 8 weeks seems like a long time, but you can look, just looking at this, at how busy it looks. There's a lot that goes into it. And we wanted to figure out, there were a lot of holes in the system, and we found ourselves many times at the hospital on week 7 and week 8, finishing and completing discharge teaching frantically, trying to get it all done. It wasn't fair to our staff, and it wasn't fair to our families. So what we did is we came up with a plan. So if you take a look here, we actually took it to the point pre-admission to Mount Washington, where our nurse liaisons who were out there actually would go to the families, and we actually have a form that has the expectations for these families before they even walk in the door. They know what their expectations are and what is expected of them. A lot of these families, like we shared before, are in the ICU for months, a lot of times using up all of their leave. So by the time they get to Mount Washington, at least one of them has to go back to work. Again, we have expectations of them. So it takes a team, it takes patience, and it takes understanding. So on the day of admission, we actually got feedback from ladies like Nicole and other caregivers, and they said, please don't inundate us that first week. We're already in that zone of transitioning over. They're in a haze. They're still in shock. They're still getting used to this new world. They've left the comfort and the safety of that ICU. Now here they are coming into a brand new environment. So day 1 and week 1 really is all about getting to know them. And I think the key that really plays in this is getting to know these families, letting them know that we're their team and we're here for them. So you'll see, like in week 1, just introducing themselves. So on the first week of admission, respiratory therapy literally is going in and introducing themselves to the parents as a part of the team. When we started coming up with all of this pathway, we also realized that in order to do this effectively, we had to do it on many different layers. We had to kick up our discharge teaching paperwork. So at this point, respiratory therapy actually gives a trait guide to our parents that we worked on tediously for months. And they walk through it with the parents, and they give them a little bit of an idea of what it's going to look like. It's a good place also for social work to sit down and have conversations, to have this hard conversation with the parents, and identify any barriers that might get in the way of anything on this path. One of the things that we've actually run into a lot lately is English as a second language. So really we need to take that into account, taking the time to get interpreters in, and looking for other options for these parents so that we can navigate them through this very complex system very effectively. Within the first week, they observe the first trait change. By week 2, we're already setting them up and getting their focus ready for discharge, where they're signed up for CPR and they actually get to participate in that first trait change. So as you navigate through, they do, I think by week 3, they're actually doing their second trait change. By week 3, they're signing up for the sim lab. They're saying, okay, on week 4, we're going to sign them up. So sometime around 5 or 6, they're going to come up to the sim lab and they're going to do the what-if scenarios that we'll talk about in a minute. Case management at that point is really on target with looking at all of the processes that need to take place into getting these kids transitioned home and the equipment that's needed. A lot of times they'll talk about transportation issues with the families as well. All right, so I'm actually going to move on. We'll talk a little bit more, and this is something that if you want to take a look at closely later, we're going to have available for you to print off, because this is what our picture looks like, but the whole point and the whole key of this was to come up with a pathway that all disciplines can feed into. When nutrition comes up, they get to take a look at this, and they need to plot out where they're going to fit in their education with these families. When respiratory takes a look at this pathway, they can take a look and see what they're responsible for and what nursing's responsible for. I'll tell you one thing that did come up, and this is where you need to get ready to put the time in, to have patience and be committed. This looks really pretty on paper, but to actually make it work and to come into real practice, what we decided to implement were walking teaching rounds. So every Wednesday morning, we all had to take time out of our schedules, which are really busy, and we set aside a half an hour. We actually walked bedside to bedside, because we are now getting all of our interdisciplinary staff to have to rethink the way they talk. You take a bedside nurse months ago, and if you asked her what week of stay a kid was in, they would have no clue. That's the kind of terminology that case management uses, but we now needed to extend that to all of our staff. So we do walking rounds, and we're holding people accountable. When we're on week 5, we want to make sure that those caregivers have already done each 2 trait changes. We want to make sure that they're signed up for the sim lab. We want to make sure that they've already done their CPR so that no one falls through the cracks and there are no holes and no surprises a week or two before discharge. Again, just trying to make it intimate and to make it real, we came up with a letter. Again, we're all pretty familiar with simulation, but a lot of our families are not, and it can be kind of scary. It's kind of the unknown. So we try and welcome them and allow them to be a part of the team. So this is just a letter that we give to the parents on admission, just again, setting that expectation. So we talked a little bit about simulation and some of those skills that we talked about before. We can teach our parents in a sim lab at bedside or on their child how to do some of those skills, how to take care of the trach, how to take care of the GT. But again, was there any real proof that once they were home that these skills were able to transfer into those emergent situations? Again, at the bedside, they had the nurse, they had the respiratory therapy right there. They felt safe. Well, when they go home, there was going to be no respiratory therapist. There was going to be no nurse. So we had to assure and put them in a situation where they could feel what it was going to really be like at home. So we came up with 4 consistent scenarios that kind of related to all of our trach kids. One was what to do when the trach came out. Another was just really identifying those early signs of distress, knowing when to call your pediatrician. Here you'll see here, the mom, here she is, alone in the sim lab. One of our scenarios is where the vent's high pressuring. This particular scenario actually leads to where it was high pressure because there was a plug in the trach, and we actually had the kid turn blue and actually go into a code where the mom actually needs to call and implement CPR. So I'd like you to meet the Rode family here. If you notice, we're not using one of the high-fidelity sim dolls. This was actually one of the earlier barriers that was identified, as you saw in that pathway. This was a family that early on, it was identified that mom would be the primary caregiver. And a couple weeks in, dad lost his job. So it made complete sense that he would be home with the baby. So we had to actually transition and put the primary focus on the dad. So we brought them pretty early on in their stay up to the sim lab. And one of the neatest things happened when we brought them up there. I was in the room at this point. Again, we were going over basic skills of changing the trach and teaching CPR. Mom actually was able to feed in. She knew dad well, and they actually kind of learned that little song and dance. And mom kind of took over some of the teaching. And that, I think, helped de-escalate dad a little bit and took away some of his anxiety. In fact, right after this, he had really not touched the trach too much on his own baby. He was able to leave the sim lab and actually change the trach that day, and he did it quite successfully. And one of the neat things was we actually did a follow-up phone call several weeks after with this particular family, and they were very excited. They shared with us how weeks after discharge, mom felt so confident in dad that she was actually able to leave and go on a weekend to a wedding that had been planned with her friends and leave dad home alone with the baby. It's something that we all take for granted, but this, again, restored that quality of life back to this family, something they thought they would never have. So again, we knew what we were doing was good. We saw the changes in their confidence, but we had to find a way to prove it. So we came up with an evaluation tool. So we used this tool. We've kind of tweaked the questions throughout the month, but again, it's remained consistent. We asked the same questions before, and we asked the same questions after. I will tell you consistently, above 90%, that the confidence level of these families rates extremely high after their training in the sim lab. So again, I talked earlier, so our story should have ended here. But one of the things that we actually recently have endeavored on is as we were going bedside to bedside, like I told you, weekly for our teaching rounds, one thing that we noticed is that the parents were always at the bedside. These kids were tethered and stuck at the bedside due to their ventilators. Because as a lot of you know, and if you've worked with these kids with vents, the home care vents don't come into play and don't get delivered until a week, perhaps 2 weeks prior to discharge, which means they sit at the bedside for approximately 6 weeks. So we decided restoring that quality of life can't wait until they go home. It needed to happen while they were here at the hospital. So we put together these transition home outings. And if you see the highlighted pieces, it's because we're still in the process of rolling this out. But for the few families that we've done it with, I'm going to share with you in a minute, we have found amazing success. So the baseline outing will happen at bedside. It's where the parents have to have CPR, they have to have completed their trach changes, and they've had to have at least come to the sim lab at least once to prove that they're competent. If they've done that, then we afford them a little bit more quality of life and freedom, and we allow them to now independently go out on the unit. We have them bring their stroller in that they're going to be using and their car seat. So the car seat test has to be done early on. These are all things that prior to a year ago were happening the week of discharge. Talking about stress on staff and on the families, it was too much. So here we're able to work it out. If we find out that the stroller doesn't work, the families still have weeks to go back and change that. Our final outing, which was probably one of the most exciting, is the week or two before discharge with all of the equipment in the hospital. The parents get to do a trial run or two to the car. It's something that we've kind of taken for granted before. If you can remember back with your own kids, if you have them, you can remember that first time trying to put the kid in the car seat with your 2-year-old running around, and then you've got, your diaper bag, and trying to put all that into play. Well, just picture these families who had been in the safety and the security and the watchful eye of the respiratory therapists and the nursing staff in the hospital. All of a sudden, they're given the okay to get in the car and go home. So this trial run we found was life-changing for many of our families. We actually got such buy-in from our nurse management that they're actually proposing the idea of having a sign put out front and a parking spot just for these families. So here you go. If you want to take a look, this is one of our little patients actually for the first time in her car seat. She's ready to go home. Here's another family looking at all the equipment they have. It gives them a chance to communicate, to talk, and to work out all the kinks. If you look at this as a low-lying car, so their situation is different than someone who has an SUV. This little baby in particular is tethered to a ventilator. So who do you put in first, the baby or the vent? Something on the day of discharge would just be too much, and we had asked of our families. This family in particular was high with anxiety, and were so nervous and scared for that day that they would hear those words, "It's ready to go home." So for them, this actually practice run to the car really prepared them, and their confidence went through the roof. And after this day, they were excited and couldn't wait to see that baby back in that back seat of that car. So again, what I want to stress and what you really need to do is have a lot of patience, because it takes collaboration from all the different departments. You've got to have buy-in. So it really takes sharing your story. Again, our story has evolved over a couple of years, and we've had to and still remain working on it. Here's a family right here transitioning to go home. The family is an important part. You've got to get buy-in from your families. Here's Nicole. And actually, this story, I would really should have updated it. An exciting story. Kaylee now is 4 years old and decannulated and a healthy, well on her way to being a normal little girl. They have been given full quality of life back. If you can tell me they don't believe in simulation, I'll tell you right now, Nicole is still our biggest advocate. So I have shared a lot, and this has been our story. I hope our story changes your story, and that you see the need and the importance for implementing not just simulation, but these scenarios into your transition home teaching. So I've brought into the room our director, Sharon Meadows, and she'll actually be able to answer some of those really important questions I know a lot of you have. And it's all, this is well and good, but how do we get from point A to point B, and where did that budget come from? So I'm going to open it up to questions, and I look forward to collaborating with all of you in the future.
Wow, that was great, Linda. Thank you so much. Actually, I think that's a great idea to move on to this budget issue. And one of the questions we have is basically just an overview. I mean, I know you mentioned there was a gala at one point, there were grants, but could you give a little bit more detail about how you even found out about these opportunities for grants, Sharon?
Yes, good afternoon. Thanks for having me. We started with, way back when our first acquisition was SimBaby, and that grant actually came from our hospital foundation, which our foundation has just been wonderful to us in they offer grant opportunities every year. So we've received a few grants for them. Actually, both our simulation mannequins came from them. And then we just did a search of grant, out on the internet grants, and sort of tried to keep it to the Baltimore area. Is there any corporations in the Baltimore area? And we came across a local Catholic charity that offers grants they have ongoing grant process. So I just searched, and then I found one that I thought would support us. It was very hard being a small hospital with not a lot of research grants going on to find that money, but I found one that didn't require research, and we applied, and they've actually given us 2 grants, and their latest grant really that allowed us to contract with EMS and upgrade our sim lab. So really it's just if you don't have grant writers in your institution, it's going out, searching the internet. It takes most grants. You have to do a lot of writing, but it just you just go piece by piece. And I had no experience with grant writing, but we were granted 2 outside grants, so you can do it.
Well, hopefully people are listening to that, because this idea of the grant is something that we did get a couple questions about, so that's good. Okay, anything else on the budget that you guys want to mention? Because I have a couple questions here that are more about the educational part, but I don't want to lose track of this budgeting issue. Is there any possible recommendation besides the grant search that you can make to the people listening?
On my end, really quick, Chris, one thing I'll tell people to do is not to wait, to be working on that in the meantime, but to start small and be creative. I didn't mention it, but when we first had our sim baby, he was actually kept in a cage on the 3rd floor of the hospital. And every time we wanted to use that doll, we had to make a commitment to finagle him down a ramp and down 3 flights of stairs to the classroom. So again, like we had shared before, that backdrop with $150 to the crash cart that we were able to paint for a couple hundred. So it's a process. So I encourage people, and word will get out there. I'll tell you right now, we didn't get a lot of attention with simulation, and it wasn't because people didn't want to. It's just because it wasn't so obvious. But when you're out front painting crash carts, you get the eyes of the CEO of the hospital. When you hang that backdrop, they stop and look, and they start paying attention.
Yeah. And as far as budgeting, all hospitals, I'm sure, or anybody in healthcare, or even if you're listening in from the schools, you just have to put it in there and be able to defend it. Whenever I put something new in the budget, I do literature search, I talk to other hospitals and find out what they're doing, because your hospital wants to be on the cutting edge. And so, you just have to keep trying. And like Linda said, starting small, and just go ahead and do it, because once our administration and our medical director saw us out there doing mock codes and bringing staff up to the classroom to practice IOs and that type of thing, they start to see the worth of simulation. And eventually, it took a couple years, but each year we got a little bit further. So don't be afraid to start.
Thank you. That's good. Okay, I want to move on here to a question about the mannequins that you used. These are some more specific questions about your experience. So for the pediatric mannequin, you mentioned Hal. Is there a specific one you were using that turned blue, and how did that happen? Was that moulage or the mannequin itself? And that's from Sarah.
Yeah, Sarah. Yeah, so the neat thing about these high-fidelity dolls, no matter what company, because now you have options. The high-fidelity ones all turn blue. In fact, there's a new one that's out there by Gomard that is a preemie that is amazing. Right now, when they turn blue, it's a light from under the lips. So they're even advancing. I mean, every day there's something new coming out there. But the high-fidelity dolls, pretty consistent that they are able all to turn cyanotic.
Great. Okay. Another question came in about debriefing, and this is from Agnes, and she asks, When we debrief, we usually talk about learners, and those learners a lot of times are used to debriefing. They do it, or at least they can get used to it because it's something that might be a requirement in their class, if you will. How was debriefing, or was it done at all with the parent, with the caregiver? Was there a sense of debriefing as being important? Was it challenging?
Okay, that's a really funny question, and I actually am recalling, if you remember back to the slide where I shared the one mom that was in the room that had a plug in the trach and then it turned into CPR, well, what you didn't see, who was in the room with her, and it wasn't me, was the grandmother, who's going to be the backup caregiver. Well, I will tell you right now, it was amazing to watch. Before I could even shut off the simulator and get back into the room, they had already naturally started debriefing themselves. They were asking and talking and collaborating and asking, okay, so wait, what did we do? Did we call CPR? Okay, we should have went a little deeper. So they naturally started it. I think it's an innate part of the adult learner that we want to reflect on it, we want to make sense of it, we want to be able to apply it, and I think we do it almost naturally. So I have found most parents to be exceptionally receiving of it.
That's great. Okay. And a kind of related idea about, learning in general. One of our listeners, or Sarah actually, is asking or commenting, I can see an application for this in teaching pre-licensure students. So this concept for patient teaching is something that possibly could be used by students anywhere when it comes to simulation, being able to teach and that sort of thing. And I like the example also, as I was reading this, I was thinking of what you were saying about the mom being able to teach the father because, she knew him or whatever. Can you comment on that a little bit more about this idea that the caregivers themselves are a type of learner? And you mentioned adult learners, but how does that possibly compare to a more standard learner who might be in a pre-licensure program?
Well, I think you need to know your clientele, I would say, because not one caregiver, not all apples are the same, is what I'm trying to say. So we have to use a lot of different modes. Like, remember I mentioned before, we're getting a lot of parents as English as a second language. So if that's the case, we've got to bring, the interpreter up. And looking for their cues. I think that's key, because you can't put them all in the same box. Yeah. I actually remember I was teaching CPR to a family, and I didn't get the backstory that the whole reason that this child was in this situation is because the mom, with no training, had to start CPR on her child at home. So that whole topic of broaching CPR was extremely sensitive and actually could have been a big barrier to getting in the way because of mom's life experiences as an adult learner, and she had walls up. So knowing that information helped, and we were able to take a different approach with her. So I think you have to know the learner.
And it sounds like from what you said too, the survey is giving you sort of the proof of all this. Can you talk a little bit more in detail about the survey or the pre and post that you did? A little bit more about the specific points that you were asking about?
Yeah, so what we're doing, and this is a little exciting, as you know, we're jointly owned by Hopkins and University of Maryland. So again, this whole idea and concept that we're doing is something that is taking off. But again, you want to be able to validate it. So we actually have teamed up with one of the doctors at Hopkins, and we're actually going to try and put together a study on the outcomes. So we're in the process of doing that right now. So we're looking at things like specifically how many of our parents are English as a second language, what is their education level, what is their home environment like, how much family support do they have, financially, is it a one-income, two-income family? Will they both be working? Will one be working? So we're trying to find out exactly who we're dealing with and how to do it better. So the evaluation really helps us with that.
Awesome.
So, and I'll tell you one thing to add on your evaluations is a comment section. Because again, nothing is ever in the box. I will tell you, I keep tweaking our evaluation because of the input and the feedback from our families. So I think as we continue to evolve and this evolves, we need to keep evolving with it.
A follow-up question from Paul. Has there been any challenges in terms of getting to know the family? And I personally, I found that kind of interesting too. It sounds like you guys are making an amazing effort to get to know each individual family and their needs. But what have been for you the challenges there?
A lot, to be really honest. Again, we talked about parents' time is limited. So we set the expectations, but it doesn't mean they always can. I mean, I can tell you how many appointments we've made where I've set my afternoon. I told you we're hospital-wide education. So this is only one piece of what we do. And we'll set a couple hours aside to meet with these families, and then life happens. Another kid at home gets sick, or the parent gets called into work. So it's tough. We've had to be flexible, and we've had to make the commitment. But we also ask the same thing of our families. So we have those tough conversations with them and accountability. We reach out to our case management. We don't work independently. We work as a team to meet the needs of these families.
One more question, and I just want to remind the audience, if you do have any questions, you definitely can send those along. I have one more question here kind of related to this with the family, and that is specifically about the realism. One of the things we talk about a lot with simulation is, you know, that suspension of disbelief and being able to treat a mannequin or a, you know, whether it's low or high fidelity as the real thing. What was that like, that process of acclimating the parents, the caregivers, to working on a mannequin first?
You know what? You've got to make it as real as possible. So all you need to do is put them in a room and have all those vent alarms going off. If you want to see realism take place, that's a good place. Because they've got it down pat until you've got all the distractions going. And you have to have those conversations. You have to actually prompt them a little bit and say, look, I get that you... So again, look at the size of Hal. A lot of our parents that are coming through right now, their babies are half that size. So I need to have that conversation with them. And it seems like it would be a barrier, but I guarantee you, once they get into those scenarios and they pick up that suction catheter and they get themselves into that scenario, that kind of goes by the wayside.
Laura asks about the adult population. So we're talking about a pediatric hospital here. Are you aware of any situations that are similar, or any hospitals where the adult population is, you know, when there's a caregiver for an adult population, if this would be similar?
I think it would be similar to if you have an adult and you have an adult caretaker. It could be a spouse, it could be another relative. I think simulation is simulation. It works for whatever audience. I think just the idea that you're allowing people to practice a life-threatening situation in a safe environment, and by repeating it, that hopefully when it's time to, it happens in real life, they're able to at least think back to what they did in the simulation lab. So I think it would be appropriate in any age.
Yeah. Simulation is simulation, no matter what.
Exactly.
And on that note, if there are no further questions, I want to give Linda and Sharon a moment for a final word.
Yeah, so one thing as we're talking too is I wanted to make sure, and I had mentioned the word earlier about collaboration. Again, this is an area that we can't be selfish in. Like, if it really makes a difference here at Mount Washington, it needs to be done everywhere. So I would love, and I'm okay with Chris sharing my email contact.
Definitely.
And I'd love to hear what people are doing. I've had recent conversations with other pediatric hospitals that have started implementing this, and it's been a lot of fun. I'm learning from them. So I'd love to hear from you. So I am open to receiving emails and would love to have a phone call with you or an email, exchange with you.
Oh, I appreciate that. Thank you. So we will get that moving on our end. That's good.
Yeah.
Okay.
Very good.
All right. Well, thank you both so much. That's all the time that we have for today. On behalf of the Global Institute for Simulation Training and Education Management Solutions, I want to thank Linda and Sharon, and also you for attending. So we look forward to seeing you again in June for our next simulation webinar. Have a great day, everybody.